Hey Goldberg, why are you here?
Jim, please. Jim.
That's for the money.
Lee, how long have you been around?
I joined the faculty at Penn in November 1998, so this will be my 20th year in the program.
Thank you to both to Lee and to the social workers and to the staff that are here. Without them, we wouldn't be here. Simple.
Absolutely.
And I'm Jim Gleason, and I'm the host for this on behalf of both TRIO, Transplant Recipients International Organization, and the HUP Second Chance Heart Transplant Support Group. And I'm out 24 years trying to catch up with John over here. He's 25. He's got some leg problems, so he's going to slow down. Maybe I can catch him. I don't know. Anyway, real quick, just to give you some idea of some of the things that TRIO does in the local area you might have some use for. We put together a book about transplant for children of families facing transplant. In other words, the child isn't facing transplant. Somebody in the family is, and this will help explain. I have about a dozen copies here. They're free, put out by TRIO. We're in our third printing now. And so if you have a grandchild, we have a family that needs this, all you have to do is see me after our talks are over, okay? Second thing we do is we have a transplant presentation library. These are YouTube videos, and we now have put all 100 programs up on YouTube. And if you go to the TRIO website, trioweb.org, or search on TRIO, get past the TRIO Philadelphia chapter, the Maryland chapter, all the chapters, you'll find our main webpage, and up under resources, the Transplant Presentation Library. As I said before, we're recording today's event, as we do all of these events, and they will be up on YouTube from that point on. So there's 100 YouTube videos of all types of people talking about issues that you'll be fascinated with. And so you always know we're doing that. If you can't make it because of snow or whatever, you can always catch it later. The third, one of the most important things we do, and you know it's interesting, we are concerned about the higher risk of cancer in transplant patients. A lot of programs mention this up front when you're getting listed, but then they don't follow up. The heart program does an amazing job. As I've often said, once we get transplanted, they own us. And I say that in a very positive way. I can remember when I was brought in here by ambulance with diabetes at 2 o'clock in the morning. The heart team was outside the door waiting for me with the scale. I mean, that's the way they are. When you come in here for something, all sorts of discipline teams could be here to support you. They all report to the heart team for oversight on what they're doing. And so, one of the things we get reminded of is to have your checkups, all those kinds of things, and I know Lee's going to cover that because it's certainly key to life 2 years out. And so we have a 5-year program, and in that program right now, the first deliverable is a website of information about, first of all, learning by organ type about the risks of post-transplant cancer. Second, under look, what do you look for? What symptoms do you look for? By the different cancer types, skin cancer being the most prevalent, for example. What do you look for? And finally, living with cancer, both preventative, diagnosis, treatment, and long-term survival. And then finally, we have a resource under links that include things like our transplant faculty, doctors who allow us to videotape their conversations about these issues, and they're integrated into those various topics. People felt that that was a little overwhelming, and so when you go there, this is what you'll see. And so on the left-hand side, you see the learn, look, live, and link, and that'll bring you down to those sub-menus. So if you go to the trioweb.org website, up on top, you'll see the TRIO PTC. You can click there. Or if you've got a good memory, trioweb PTC, post-transplant-cancer.org. Either way, or just search on it. And so that's out there to help you live longer now that you've survived the transplant. And so our daily challenges, I often remind our audiences here, we do not defeat death with transplant. Rather, we gain an extension of life. And so the real question becomes, what are we going to do with days, months, and hopefully years of extended life? The same question, even the non-transplant patients own lives, the caregivers as an example. And so, by way of inspiration, I said, quote from a heart recipient, that's me. And in the UNO's book about what every patient needs to know about transplant, this quote is in there. I want to live until I die. And let me tell you something. As you get older, you're going to have other issues, not necessarily transplant related, because you're getting older. And as you take those medications longer, you're gonna have more issues. You get to live with it as best you can, right? I just passed my 75th birthday, 24 years out. 25 years ago, I went out to Chicago to attend my daughter's graduation from the University of Chicago. I was so exhausted when I got there from a failing heart that I laid down in the bed after climbing 3 flights of stairs and went to sleep. I missed the graduation. They got me back earlier, got the transplant a month or 2 later. A year later, we went out to Chicago again for the baptism of my first granddaughter. Tomorrow we leave for Rochester to attend her graduation from college. Isn't that what it's all about? And so I want you to live until you die also, whatever that means in your world. And so with that, oops, do that. We're going to hand this over to Lee. And you've got the mic on. Turn it on. So, great.
So good morning. So it's exciting for me to be able to tell you a little bit more about the details of what we look for post-transplant and kind of why we put you through these annual evaluations and some of the rationale for what we're looking for and what we're thinking about. And a lot of what I'm going to talk about are things that you've heard about kind of during your transplant teaching, but so much has happened between then and now that it's always good to kind of review and think about it. And our thinking about this has really changed. And we're blessed in the sense that here at Penn, we're working in an environment where we have a cancer center that's actually doing groundbreaking work, right, in immunology to treat cancer. I'll talk about that in a few minutes. And we kind of get the benefit of that, by kind of understanding more about immunology and how cancer works, et cetera. And that ultimately is going to change the way we think about it for people that are on the opposite spectrum. Instead of turning on the immune system to fight cancer, we're cutting back the immune system to prevent rejection, but does that increase the risk of developing some cancer? So we'll talk about that a little bit. So you made it through transplant, which was the goal for all of you, and I'm fortunate I've been here long enough that I remember the days that some of you were transplanted and were involved in some of that decision making. And our goal too is to kind of get you to transplant, right? To get people from the waiting list successfully to transplant and recover that initial phase. And so that's really the goal. And then when that's all done, there's like the sense of now what? Now I've kind of hit my goal. How do I live my life? What's next? What can I expect? And so this is what I really want to focus on, like now what? So we know that the immunosuppression medicines that we're forced to use, the current ones that we have, increase the risk for certain medical problems downstream. We know that if you had conditions before transplant, diabetes, hypercholesterolemia, kidney disease, whatever else, those problems are still there even though the heart was replaced, and so we have to manage those pre-existing problems. A family history still matters, right? So if there's a history of colon cancer, there's a history of breast cancer, there's a family history of stroke or whatever else, knowing that is also an important issue for us, because although we've addressed the heart issue, we still have to understand that you still have your genes and the risk factors are still going to be there. And then you are also allowed to get stuff that everybody else gets. So just because you're a transplant patient, you don't get a pass, right? So you can still catch the flu, right? And you can still get a GI bug, or you can eat romaine lettuce and get E. coli, right? So the same as any of us, you're at just the same risk as anybody else. And so we have to kind of think about good kind of primary care for you, because it's anything that anyone else can get, plus some extra stuff that we get to give you that's kind of the cost of having the transplant. So that's how we as a team try to think about prevention and screening, etc. So when we think about immunosuppression, it's really a balancing act, right? We have this issue of preventing rejection, which is our #1 goal. And early after transplant, we run those immunosuppression levels high. You guys have experienced the side effects of that, right? The tremors from the tacrolimus and the prednisone side effects and making people grumpy or moody and all that stuff that goes on. We're doing that early on in order to prevent rejection. But over time, we know that we're balancing that against the risk of infection. And it turns out that not only does our immune system fight off infections, like viruses and bacterial infections and whatnot, but our immune systems also kind of scan our bodies looking for cells that might be abnormal and misbehaving. And long before they become anything bad, it kind of bumps them off. So our immune system kind of clears away things that may ultimately develop into cancers. But every day, probably hundreds, maybe thousands of these cells are detected by our immune systems and are wiped away. But we know that with immunosuppression, we begin to inhibit the body's ability to do that, right? So the immune system is not as robust, and therefore, some people may go on to develop cancers that are kind of unmasked by the immunosuppression. We sometimes think that they may have ultimately gone on to develop a cancer later in life, and maybe it's happening sooner because they're on immunosuppression, so we didn't really cause the cancer, but rather we're letting it manifest itself sooner than it otherwise would. And so those are kind of the trade-offs. And so you know that as we've gone post-transplant, some of you are many, many years out, some of you are just beginning your journey, that we kind of lower the immunosuppression levels as we know the body gets a little bit of tolerance to the transplanted organ and we're kind of past that initial phase, we try to back off. And one of the reasons we back off is because we're concerned about the long-term toxicity of the drugs, both directly on things like the kidney and liver, but also indirectly in the development of cancers and other opportunistic infections. And so that's kind of the balancing act that we're always playing between rejection, infection, and cancer. And I just wanted to highlight one thing that has been in the news so much. You know that here at Penn, they invented a way to actually turn on T cells to attack cancer, right? And this is an unbelievable breakthrough. This is targeted personal therapy. This is your personal T cells somehow being activated in the lab and mixed up with some juice and then given back to you and causing a big sickness to occur, but your body literally fighting off the cancer using your own immune cells. Of course, these T cells are the very ones that my colleagues and I are trying to turn off in all of you, right? Because those T cells are the ones that are responsible for also rejecting foreign organs, right? And what they do in this CAR T therapy is they actually make the cancer look like it's foreign, right? And so the body then will attack it and naturally destroy those cells. So of course, my cancer colleagues are busy turning on T cells, and all of us in transplant are turning off T cells, right? So we're on the opposite side of the spectrum. But I wanted to give you a sense that there's an amazing science and things that our colleagues are learning in cancer this year, in the next 5 or 10 years, may revolutionize what we're doing in transplant. Because they're learning the secrets, the biology of these cells in a way that I don't think we would have even been able to foresee, say 2 or 3 years ago. And now all of a sudden we have therapies, and just the past week, another cancer was approved for therapy with this particular approach, and I suspect there'll be even more to come. So more to come on that. And partnering with these guys may actually teach us a lot about transplant. And we as a group have been thinking about, do we need a specialized physician in the Transplant Institute that just focuses on that science, on bringing that science to individual patients and helping us tailor therapy. And I think in the next year, we have enough traction now that we're going to actually bring a faculty member on board, a physician who will just focus on transplant immunology with us, because it's gotten so complicated. We need someone just to focus their full time on that to help bring that information to all of us. So that's kind of a little bit of foreshadowing. So what about cancer risk? Well, I already hinted about this a little bit. You know, the immunosuppression medicines do make it harder for our natural immunity to kind of detect and destroy these cells. And so it increases the chance that a cancer cell may kind of get through the sieve, so to speak, and allow it to multiply and multiply. And we know that once a cancer forms, that the chance of our body being able to wall it off is actually also reduced by immunosuppression. And so cancers in transplant patients tend to spread more quickly, which is why early detection is so critical, because we don't have as much time as we might say in somebody else. And so we worry a lot about that. And there are 2 general categories of cancers that we worry about. One are the lymphomas, which is actually cancers that involve the lymph nodes of the body, the glands that you'll feel in your neck, etc., under your armpits or in your groin. And these are probably related directly to viral infections that transplant patients or anyone can get. And this leads to kind of an abnormal growth of the immune system as it's trying to deal with these viral infections. And interestingly, we used to treat these like they were traditional lymphomas with chemotherapy and everything, and people did not do well. When I was a fellow, if you got PTLD, it was not good news. And now, work that we did here at Penn, actually with Donald Tsai and duplicated other centers, we've learned that if we just back off the immunosuppression for a few months, our body will naturally then be able to fight off those viral infections. So we take a little bit of risk for rejection, but we're able to fight them off. And so the PTLD that used to be such a big deal post-transplant for heart, but also for lung and liver and kidney, it was not unique to us, is now a little bit less of a big deal. And we have some very specific drugs that actually can target these cells. And this is work that was done in the lymphoma world of oncology that now we're applying to cardiology. But typical cancers are actually rising in our transplant population. And there's good news and bad news there. The good news is people are surviving 5, 10, 15, 20, 25 years, you heard, right? Over 25 years now, the chance of developing a cancer in the whole population goes up, and in our group, probably up a little bit higher. So our success in keeping people alive and healthy and active and all the wonderful things that you heard is also putting us at risk that over time, we're going to see more solid cancers and the typical cancers that people get, prostate cancer, skin cancer, etc. And so what should we do? Now that we know that you're at higher risk, what are we doing about it? And so we know that we want you to avoid exposure, and I just put to stuff, that we know increases the risk of damage to cells, and that can lead to cancers. And the obvious ones are avoiding smoking and secondhand smoking. There's a paper when I was a fellow talking about lung cancer risk in heart and lung transplant recipients who returned to smoking, and it was like unbelievably high, 30 times higher than the general population. And we think it's because every time people smoke, a couple of those cells are injured, and then our immune system would wipe them away. But one day, one of those cells gets injured by cigarette smoking, and that then is able to grow into this little cluster of cells, and then ultimately over weeks to months, maybe years, develops into a lung cancer. And so being exposed in that way is something that we worry about. And then sun exposure is the other one that we harp on. Any of you that have seen Dr. Miller and his colleagues in the transplant derm clinic, I'm surprised they don't just spray you with sunscreen as you walk in the door and then put a hat on you and wrap you in gauze before you're allowed to go out. I see him too, and he yells at me all the time, and I'm pretty covered up most of the time because I'm here inside with you guys. But nonetheless, sun exposure we also know is really important. And also during my training time, there used to be a registry that was ran by the University of Alabama, and they actually did a look on cancers. And there were so many skin cancers in the data set that we actually couldn't analyze the rest of the data because nearly 100% of the patients had something taken off that turned out to be either cancerous or precancerous. And that was the first paper that said, hey, skin cancers are super common and that we really need to focus on that. And our dermatology colleagues are really aggressive about screening and taking care of that. But avoiding sun so that the radiation from the sun doesn't hit the DNA in one of your skin cells, cause it to get damaged. That cell then loses its ability to control its way of dividing and can turn into a skin cancer, and our immune systems are not as good when we're on immunosuppression to be able to knock that off. And so that's why we think that skin cancers are so common. We as a team also work to use the lowest amount of immunosuppression as possible to try to strike that right balance. And in the next few years, there may be some very specific laboratory tests that'll give us a sense of the activity of T cells. And are we kind of over immunosuppressing, or are we under immunosuppressing? Kind of where's that right balance? And so we're hoping the first generation of these tests has been available, and the results have been kind of mixed, I would say. We learned a little bit, but I don't know that it's revolutionized our field. But I think that now that our CAR T guys are working on T cells on the oncology side, we understand the biology of these cells. Some smart person is going to come up with a test that's going to let us be able to gauge the activity of T cells. And maybe that will enable us to kind of really tailor, not using drug levels of TAC like we do now, but rather the actual pharmacologic activity of the drug on the T cell that we want to inhibit. So that's a future way to go. So because we know that cancers are important, our program as part of our annual evaluation project that we do for all of you is very focused on cancer screening. We have good data from our program, but it's not unique to us if we look around the world, that if we detect cancers sooner in our transplant patients, they do better. And since we know that just by being on immunosuppression you're at higher risk, we made the decision to follow the high-risk cancer screening guidelines. And what does that mean? Well, the American Cancer Society puts out guidelines and says, if you're an average, say, American person, what do you need for screening in terms of colonoscopy and breast cancer and mammograms, all these types of things, right? And there's a low risk and then a high risk group. If you have a family history of cancer, if you have certain other diseases, they put you in the high risk group. We decided as a program that just being on immunosuppression, regardless of your other risks, causes you to be at high risk. And therefore we follow that kind of more aggressive surveillance because although we don't know the risk for all the individual cancers, we feel like it's got to be higher than the general population because you're on immunosuppression, and therefore we follow those guidelines. And so we recommend colonoscopy every 5 years, and many of you have been harassed about that from us, and we ask you to get those done. For men, we're looking for annual PSA and rectal exams. And then for women, mammograms, pap smear, GI exams annually, although there may be an upper age limit for that now. The guidelines are changing. I will note that yesterday, the guidelines for PSA screening for men changed again. So when we were saying, oh, don't worry about the PSA if you're 55 to 70, you know, now they're like, well, maybe you should worry about the PSA again. So these guidelines change periodically, and they're controversial, and I'm not smart enough to know what the right answer is. We try to use those kind of professional recommendations from our colleagues in the Cancer Society to guide us. But you guys are experiencing this firsthand. So when you come for your annual, there's a checklist of things that we ask you to do, and that includes a lot of cancer screening. We also do chest x-rays. We're looking for lymph nodes for that PTLD, that lymphoma. We're also looking for any nodules or any changes in your lungs. And believe it or not, there's been a new screening protocol for lung cancer that involves using low exposure, low radiation CT scanning. And we just met with our colleagues in pulmonary to talk about if we really think someone's at risk, is a chest x-ray enough? And then if you're not at risk, do you even need the chest x-ray? So we're starting to question whether the chest x-ray is really useful. And I think in the next 6 months to a year, we're going to change what we're doing around screening and actually risk stratify each of you and then decide whether a low dose, it actually takes about a minute to do the CT scan, looking for any nodules and that kind of stuff, because that's where the rest of the world has gone, and our program has still been doing chest x-rays, and our colleagues in pulmonary are like, wow, there's a whole new technology, and you guys haven't caught up. So we're in the process of kind of reevaluating that. So I'm giving you a little bit of foreshadowing. And then we do blood tests every single visit that we see you, and there's a lot of blood draws, but we're looking at your blood counts, we're looking at the types of white cells and making sure none of them are abnormal, etc. And those are sometimes some early warning signs for us. And then we're also screening your electrolytes, kidney function, liver function, for any clues of things that might be going on. So these are things that as a group we're doing. When you're far out and you're seeing us every 6 months, we're doing that blood screening every 6 months, and then we're doing the cancer screening and annual testing once a year. Now what can you do? We already heard a little bit about what you can do. So, you know, if you see anything on your skin or your caregivers happen to see your skin, I'm not judging, but they happen to see something on your back, then they should report that, right, that there's a change in their skin, because that's really the most common things. So any changes in moles or skin lesions. We ask that people see a dermatologist at least once a year. They're sending their kids to college on you guys because they're constantly taking something off, I think. But the idea is that you know, early detection of these lesions when they're, you know, when they're nothing is much better than when the lesions become more invasive and require more intensive surgery, sometimes leaving scars and stuff that are nasty. So early detection with our dermatologist is key. And then if you notice any swollen lymph nodes that don't go away in a day or two, if you notice any blood in your stool or in your urine, those are warning signs. Those are true for any human, right? So if anyone has that, please tell your doctor. But for our transplant patients, we really want to know that, right? Because those are early warning signs in between visits that we want to hear from you and say, hey, I noticed something that's abnormal. It may turn out to be absolutely nothing, but we'd much rather screen and figure that out and say, no, it's fine, than to miss something that's been going on for months and months, knowing that if it is something bad like cancer, in immunosuppression, it can move more quickly than we would expect to see in someone else, and so we want to kind of get on top of that quickly. Now, what about infections? Well, after the first year, your risk of infections is roughly the same as the rest of the population. It's probably slightly more than that, but there are certain things that we ask you to be careful about. So number one, use common sense. So if that little grandkid is blowing their nose and has a fever of 102 and was up all night vomiting and having diarrhea, and your kid said to you, you know, we've been up all night with a really sick grandkid, can you take him today so that I can get some sleep? You should say no. Because, you know, you're going to get sick, so don't do that. So I would say that use common sense. So avoiding sick contacts is really important. And if we happen to have an outbreak of flu, which we did have this year pretty intensely in the wintertime, then going to closely packed places like movie theaters, sometimes church, and those places where people will come anyway and then cough all over you, those are places where we'd say, hey, use some common sense. Either wear a mask or stay in the back or maybe don't go so that you're not exposed. So that's kind of using the common sense. And then there's very good data now that frequent hand washing and the hand sanitizers, although they seem like nuts, they actually work and they reduce the risk of infection pretty significantly. So having a little sanitizer with you when you're out and about, squirting on your hands periodically, actually does reduce. It's actually not just for transplant patients, for everyone in general. And I know in my house there's sanitizer, the little thing, my wife has one in every car. And then when you get in that car, she makes kids, everyone has to get sanitized. And so I think that's probably a good habit to get into just to reduce your risk. And this is just for the usual respiratory and GI viruses that we see in the community. Now, certain foods can put you at risk in addition to romaine lettuce, which is pretty depressing. There's a whole bunch of other stuff. So raw seafood is not a good idea for transplant recipients. Probably not a good idea for lots of folks, but particularly for you guys, because there are certain both parasitic and viral infections that can be present in raw seafood that on immunosuppression your body's not good at dealing with, and that increases your risk. Undercooked meats, again, we worry a lot about E. coli infections, but there are maybe other things in meat as well. Avoiding raw eggs. In my house, this is constantly about because everyone wants to eat the cookie dough. We like to bake a lot, and so there's always a lot of raw dough that has eggs in it, and we've been yelling and screaming about this, and I actually put on the refrigerator the CDC notice about salmonella from a couple of weeks ago. I actually printed out the email I got from the CDC, and I put it on the refrigerator in my house. So to say that, please don't lick your fingers with the batter, because there's a lot of salmonella, and we gotta bake or cook the eggs. And so you wanna be careful about that. Washing fruits and vegetables is just a common sense thing, but again, reduces the risk significantly. And then if you have well water in your home or places that you're staying or your family, to make sure that the well water is tested at least annually, and sometimes more frequently depending on the environment. But that is something that is in some of our materials, and just to be careful about the use of well water. Because even though you feel awesome, many years after transplant, still on the immunosuppression meds, people will develop a risk if there's something in there. For pets, you want to be careful about handling the cat litter and waste, because there could be toxoplasmosis in there. Bird cages, like stay away from cleaning the bird cages. Lots of fungal infections that get aerosolized. They end up in the air from the dust that I'll call it dust, that the birds make. It's really the poop, but it gets to be dust, and you can inhale that and have trouble. If you're having demolition done on your house, I mean like they're ripping out a bathroom to replace it or a kitchen, there could be mold spores, and so staying out of the house for a day or two while the demolition work is being done is actually pretty important, because we worry about things like aspergillus and other fungal infections, and so those are things to worry about. And the same is true around excavation. So if you've decided to add on to your home and they're going to dig a big hole in order to add the west wing to your home, you want to be careful the day that they have the bulldozers out there digging the hole, because they'll be stirring up a lot of fungal spores and stuff that are probably from prehistoric times under the ground, but will miraculously come to life 400 years later in your lung. So we want to be careful about that. And then lastly, avoiding swimming in fresh water, typically ponds, and small lakes, where there can be parasites and other organisms that most of us who have normal immune systems, it doesn't get us at all, but for transplant patients can actually be a problem. And every once in a while, every couple of years, we have someone who went swimming up in the Poconos in a pond and then comes back and has something, and we have to ask Emily Goldberg, one of the smart ID people, what to do. And so just to be aware about that. Now, immunizations is something else that we harass you about some, and now that we have EPIC kind of everywhere, we've been tracking immunizations in our system. The current recommendation is for you to get a pneumovax and pneumococcal vaccination once every 5 years. The national guidelines have been changing around pneumovax frequently, so it's been a little confusing, but we've stuck with that recommendation. And then influenza, we do recommend if you're more than 6 months after your initial transplant, that you should get an annual influenza vaccine. But I will highlight one thing in red that I put on this slide. The CDC about 5 or 6 years ago began recommending something called herd immunity. We should immunize the entire herd of humans, right, to reduce the risk. And the idea of this is that household contacts that are regularly in your home should also be immunized. And the concept here is that if they're immunized, they're less likely to bring flu into the house, because our transplant patients, although the flu vaccine works, it doesn't work as well because of the immunosuppression, so you gotta get partial immunity with the flu vaccine. It's definitely worth getting the flu vaccine because it does partially protect you, and if you get sick, it shortens the intensity and the length of the illness. However, if you've immunized your caregivers and other people that are in the home, they're less likely to bring influenza into the house, and so the concept is that that's the best way to reduce risk. So now, if we have an at-risk individual, we're supposed to counsel you that your household contact should also be immunized. We're doing that in our heart failure clinics as well, so people that have heart disease, we're saying, hey, everyone in your house should be immunized as well. And sometimes that's a little bit of a tough sell, right? Because it's like, well, it's fine that you have to get the shot, but I'm not getting the shot. So we hear that a little bit. But it actually does make a lot of sense. And when you explain to someone, hey, it's to reduce the risk of influenza coming into the home. Please remember that there's no live virus in the influenza vaccine. We took it out in 1972. So no one has gotten the flu from the flu vaccine since 1972. People believe that they get the flu vaccine and then they get sick the next week. Well, we give flu vaccine in the fall when there's a huge upsurge in upper respiratory infections, and people associate their upper respiratory infection with the vaccine, but the vaccine has no virus in it and it's going to make you sick. You may feel punky for a day or two because it does have the protein from the virus. Your body won't have an immune response. Some people get a low-grade temp for 24 hours, may feel achy for a little bit, but you can't get sick from the vaccine. So reassure your loved ones that they'll be safe and that they're helping to protect you by being immunized. There are several immunizations that you should not get. These are the live virus immunizations. These are contraindicated, meaning not to be given in someone who's immunosuppressed. So the live measles, mumps, and rubella vaccine cannot be given. The rotavirus, which most adults now you guys won't be exposed to. And then some of the shingles vaccines, the varicella vaccines, also have a live virus component, and those also are contraindicated. There's a new varicella vaccine, and we're checking with ID to find out if that's going to be safe or not. So we'll get back to you and let you know. They're still waiting on some more data about whether that's going to be safe for our transplant patients. And you're supposed to get a tetanus shot every 10 years. That's the one that hurts, man. If you get a tetanus shot, yikes. And I'm like at 9 years and 8 months, so I gotta go. So I'll be walking over to occupational health to request that tetanus shot, and my arm will be sore. I want to remind you that pre-existing conditions, things you had before transplant, still exist. So just because they're pre-existing doesn't mean that they went away at the time of transplant. And so we do have to monitor those things and manage those things. And many of you have experienced, like say you had trouble with your blood sugars before transplant, boy, just add a little steroid to that and you'll have even more trouble with your blood sugars afterwards. And so some of the pre-existing conditions become bigger conditions after transplant. And as you know, we involve a bunch of specialists from our endocrinology department and renal, et cetera, to help us with that, right? And sometimes our lipid program, et cetera. And these other conditions sometimes influence our decision-making about what other medicines we're going to use, which blood pressure meds we use, say, sometimes which immunosuppression we're going to use and why. And also we may add some additional testing to your annual evaluation because we're actually following up on one of the pre-existing conditions. So we try to incorporate that decision-making into our stuff. So diabetes certainly is a big problem for us. It can be present before transplant, but often develops because of the steroids that we give afterwards. The steroids that we give make your body more resistant to insulin, so you need a higher level of insulin to get the same blood sugar control. And also, people on steroids after transplant tend to gain weight, and that also makes you more insulin resistant. And so careful diabetes follow-up is critical. We follow the hemoglobin A1Cs, which so do our diabetes colleagues do. If you notice, we actually do screen one during your annual, just so that we're constantly screening for hemoglobin A1C, even if someone isn't known to be diabetic. And then annual eye and foot examinations kind of get added to your regimen, so to speak, to make sure your retina is okay with diabetes, and that you're not having any skin lesions or any skin breakdown on your feet. And so adding podiatry and ophthalmology to the list of many physicians that you have to see to your list is important for people with diabetes. Now, vascular disease can also be more common, and that's people who've had heart attacks, and that's what led to their transplant. Oftentimes have vascular disease in other parts of their body, so the carotids, the renals, the legs sometimes. And so screening for that is also an important thing. And we also have been screening in the right population for abdominal aneurysms with ultrasounds. And occasionally we'll do screening for worsening peripheral vascular disease. Sometimes we'll involve our vascular surgery colleagues to help us with that. Other times we'll have the primaries just do what we call ABIs, or ankle brachial indices, where they put blood pressure cuffs on your legs just to screen and make sure that the blood supply down the legs are okay. But the key thing is if you notice new symptoms, for instance, you have cramping in your legs when you walk. It's not shortness of breath or fatigue that's stopping you. It's this nasty cramp in the back of your leg every time you walk. those are things that we want to hear about because that would cause us to at least do some non-invasive testing to make sure there's no blockages. And then obviously any lesions, any ulcers on your feet, any blisters that pop and then don't heal, things like that, we want to hear about that because those are signs that there could be something else going on with the circulation, and we want to make sure that we address that. And it's amazing what the vascular folks can do now. So like all the stuff we do around the heart with putting stents in and whatnot, now they can put stents in the legs and all kinds of amazing things to restore blood supply and really give people back their quality of life, but then reduce the risk of serious infections and sometimes the need to take off a toe and things like that. So we want to be careful about that. High cholesterol is something else that we follow, and this is where there's sometimes a little bit of trickiness and a little bit of confusion. And for those of you that read your letters that we send out to your docs through My Pen Medicine, which we encourage you to do, we are a transparent practice, so you guys see whatever we're sending out to the other docs. You'll see that there's a paragraph there where we talk about the use of the statin medicines, things like atorvastatin or Lipitor or pravastatin, which is Pravachol, simvastatin, those medicines. And those are medicines that have been shown to lower cholesterol. And obviously if you have an issue with your cholesterol, we want to lower that to protect the transplanted heart, but also to protect those other blood vessels I was just talking about, right? So that's going to be very important. But one of the interesting things about statins that our colleagues in California figured out a number of years ago is that the statin medicines also modulate the immune system or modulate inflammation. And transplant patients who were on a statin were much less likely to have a rejection than those patients that were not on a statin. In addition, those patients that were on a statin, not only did they have less rejection, but they developed less blockages in the transplant coronary arteries, independent of their cholesterol levels. And we were a little bit skeptical about this. Could this possibly be true? And the answer was, it was. We did our own study here at Penn that we published, gosh, that had to be about 10, 11, 12 years ago. Some of you may have participated where in 1 year we put a little ultrasound probe in your artery and we looked to see those patients that were on statins, whether there was thickening of the artery. And sure enough, exactly as what had been reported at other centers, we found the same thing, that the statin medicines were important. So we use a statin medicine to control cholesterol like anybody else does. But 100% of our transplant patients should be on a statin medicine, even at low dose, to reduce the risk of rejection and reduce the risk of blockages in the coronaries that are caused by inflammation, not by cholesterol, that we know the statin medicines seem to ameliorate. So everyone ends up on a statin. And we had a lot of our primary care docs stopping the statins when the cholesterols weren't high. And then we'd start the statin saying, well, we're using it for a different reason. So I'm highlighting that for you to be kind of an informed consumer. And then if you look in your letters that go out to your docs, we actually have a paragraph that says something along the lines of, all transplant recipients are on a statin to reduce the risk of rejection, independent of the levels of cholesterol. We adjust the dose of statins to hit the targets for cholesterol, but everybody should be on at least a little bit of statin if they can tolerate it. There are sometimes good reasons why we don't use it. People have allergies or have had issues or whatever, and we stop it. But in theory, everyone should be on a statin, and we usually start that within a few weeks after transplant once things have calmed down. The goal for our cholesterol levels is a level of 100, an LDL cholesterol, a bad cholesterol, of less than 100 for everybody. And if you have a history of vascular disease or coronary disease in your pre-transplant state, we try to push the cholesterol even lower, down to 70. And that's more consistent with the national guidelines. As you know, there was some controversy recently in the national guidelines where we moved away from the numbers and more to this risk calculator. There is no risk calculator for transplants, so that you guys don't apply into that calculator because we don't know what the right cholesterol levels would be. So we've stuck with the old guideline of 170, even though if you were to go online and read about it, you'll see that we're supposed to be using this ASCVD risk calculator and then just going to high-dose statin no matter what, right? That's what the guideline now says. We've been a little bit more nuanced in transplant, both the risk of side effects from the drugs, as well as the fact that you guys are just, that model has nothing to do with you guys. I mean, we just don't know how to do it. So we're kind of ignoring that new guideline and sticking with the old one for now. A year from now, we may change our mind as we have more data, so that may be a moving target. But for right now, that's what we're doing. What about high blood pressure or hypertension? If we look at all the problems that people have post-transplant, hypertension is the #1 problem. And part of that's a side effect of the medicines. Tacrolimus and cyclosporin actually increase the blood pressure by squeezing the blood vessels that go to the kidney a little bit. So the kidney's like, yikes, I'm not seeing enough blood pressure. Let me make some hormones that's going to bump up the blood pressure. But the reality is the blood pressure is actually high in the body, not low. And so we traditionally will treat hypertension relatively aggressively in the program, and depending on your other risk factors, that's how we choose which antihypertensive medicine to use. So if you have diabetes and your kidney function and potassium are okay, we may use an ACE inhibitor or an ARB medicine because we know that protects the kidney in the setting of diabetes and hypertension. If you have renal dysfunction, we may use a drug like amlodipine or Norvasc because we know it doesn't have a big impact on kidney function or potassium levels, but it does a good job in lowering blood pressure. And then we sometimes mix and match and do whatever. So it's a little bit of a dealer's choice, but we really do try very hard to tailor the meds that we choose based on the other risk factors. And that's true, that would be true of any cardiology practice. It's not unique to transplant. We do know, however, that hypertension really increases the risk of kidney disease, stroke, and the vascular disease, the blockages in the legs and other arteries. And so treating hypertension becomes an important risk factor to control for all those things. So we want to be careful about that. What about your bones? Osteoporosis. Well, we know that weak bones can fracture, and the steroids that we use can increase this risk. And then long-term inactivity. Many of you were sick for a long time, sometimes in bed for weeks, pre and post-transplant, and we know that that inactivity really robs your bones of a lot of calcium. And so exercise definitely helps strengthen the bones. There's not one study on bone health that doesn't show that even just walking around increases your bone health. But we have been doing DEXA scans to look to make sure that we know the status of the calcium in the bone. And it's true in men and women. We used to think of this thing as a postmenopausal woman problem. That's not true. Many of our men also, because they've been on steroids, some of them have been on heparin for a long time, other meds that we know can kind of rob the bones of some calcium, and over time the bones can weaken. And people can get compression fractures in their back, they can fracture a hip or a leg, etc. from these weak bones. And so we screen for that. But the best way for you guys to deal with that is to actually take a walk every day. That will strengthen your bones and actually push, the stress on the bones actually pushes calcium into the bones. And so that's a great way of doing that. And then oftentimes we'll add calcium to your regimen, and sometimes we'll add other agents to your regimen as well. And we do have an endocrinologist that kind of focuses on bones with us and helps us out in terms of picking other meds to help protect the bones. Now, I will say that your family history matters, so talking to your family members about what history is going on in the family, whether there's breast cancer, colon cancer, those types of things, those may impact our recommendations around screening for you, as well as what tests we might recommend to do. So if you know that there's a family history of something, that's good to know. And I think having family members kind of be open and honest about what's happening in the family sometimes can be really helpful to you. And then your history of why you needed your transplant may also impact others in your family. So if you had high cholesterol that led to a heart attack at a young age, and then 10 years later a transplant, all of these kids and grandkids need to be screened for high cholesterol, right? Because it's unreasonable to think that history won't repeat itself if we don't do something different, right? And so all these kids need to be screened for high cholesterol if there was early diabetes, etc. And then if there's a risk for vascular disease, every family member should be advised, hey, don't smoke, because in our family, smoking and the genes that we have lead to early coronary disease. And so I try to, one of the best ways to get people to change their behavior is to personalize the risk and say, you are at risk for these behaviors because, and that kind of gets people to really think about their behaviors. But for your families, to think about high cholesterol and risk factors, etc. And then I did mention that you can get the stuff that everybody else gets, right? So you need to go to the dentist because you can get cavities in your teeth even though you had a heart transplant. And some of the meds that we give you may actually increase the risk of that. And so you got to go to the dentist. You got to go do eye care. And although I won't specifically talk about sex, at least in my top part, birth control when appropriate is also important. That this comes up for us periodically, but it is important. So it's part of just being human, right? That there are things you have to maintain, and your teeth and your eyes are one of those things that you have to do. I'm going to kind of wrap it up a little bit by talking about the things outside of you, because we've been focusing a lot about things inside of you. And you do have to take care of your whole self. And that means body, mind, and spirit. So, transplant is an amazingly traumatic event. It's life-changing for patients and families. We are honored oftentimes to be part of that in a positive way, but there's also a downside to that. People get depressed and anxious, they have PTSD from just all the things that happen to them. There can be a lot of anxiety associated with, am I gonna do okay, and what's gonna happen? And those are honest, normal feelings that anyone would have under these circumstances. And so we really, really, really want you to live. And sometimes physically you could live, but emotionally you're not there yet, right? There's still a lot of anxiety and depression and whatnot. And so I'm just taking a moment to say that even more than 2 years post-transplant, taking care of your mental health and your spiritual health and all of the other things that are part and important to your life and your family is also really, really important, because that's what makes you a whole person. And I think that's part of that living piece that we want you to do. We want you to participate in those things within your family and outside world that give you joy and make you feel useful, etc. And these things can sometimes get in the way. If you're feeling kind of depressed and down and don't have energy, or you're feeling really anxious and afraid to go out, if there's an activity that you want to do and you're not sure, ask us. If you're embarrassed to ask one of the staff, you can ask me. I get almost all the crazy questions, I think, in the whole program. And so we'll talk about it. We think it's a reasonable risk not to risk. We had one guy recently that wanted to drive a race car at Daytona. Like you can rent it for like $1 gazillion and drive at 500 miles an hour. I think it's a bad idea. And so I was like, I think it was on my blood pressure. I was like, no, bad idea. But the reason is the heart's innervated, and the risk of actually having fainting, because your heart rate can't come up quick enough and you're under G-force, is actually a problem. So I had a good physiologic reason to say, this is not a good idea for you. Let's think about other thrill activities that we can do, so those kinds of things. So if there's something crazy like that and you want to ask us, please do. On the other hand, I totally want you to live and have fun and do stuff. And so if there's any way that we can figure out a safe way for you to do stuff, go for it. And if you understand the risks and you want to take those risks, that's good too. I just want to make sure that you're fully informed and all that. So we do want you to live. So what's the recipe for success? Now to wrap it up. Always take your meds. Report to us any concerns about your health. Participate actively in these health screenings, as much of it is a pain in the butt, sometimes literally. We want to make sure that you are getting screened for all these things. It may feel like this has what does this colonoscopy have to do with my heart? And that's why I'm here today, to try to connect why we think it's important for you to have all of those things. Create a healthcare team of experts. They don't have to be all here at Penn, especially if you live at a distance, but having that local GI doc that can do your colonoscopy and the local dentist, so you're not coming back and forth here, that's fine with us. But create a team of experts that you trust and are willing and able to communicate with our team. I promise you, if we put them on the care team in Epic, they will get more letters than they care to get. I usually get complaints that we're sending too much out to the docs, pages and pages of faxes every visit. And so, let us know who those people are. I want you to avoid high-risk activities. Smoking is one obvious thing. Maybe driving at high G-force might be another. Exercising regularly, protect your bones, reduce your cardiovascular risk, maintaining a healthy weight. And then really, wrapping it up, to take care of your whole self. And I do mean body, mind, and spirit, in addition to all of the busy stuff that you have to do in being a transplant patient, not to forget to live and participate with your family and take some of that joy, right, that you've been through this traumatic experience, and really relish and celebrate that, and make that part of, kind of who you are. So I do want to thank also some of the same people that you heard about early on, Sally and Deb, Rachel, and our newest social worker, Lauren. They do a tremendous amount of work. I think you guys probably interact with them as much as we do. And they helped to set us up. And then I do want to also shout out to all the family, friends, caregivers who are here. Almost everybody came with somebody that's a testament to how things work in transplant. But it's a big burden also on everybody, right, that you have to kind of deal with. And so we want to say thank you for all of that. And then also the Heart of Gold fund that's helping to support us with these kind of outreach and support groups that we're hoping to be able to expand over the next year or two. So now I'll stop and I'll take any questions.
Now please, when you ask your question, please make it nice and loud, and if you can't hear it, we'll repeat it for you so you know what he's answering, okay? Who's got a question? We'll start over here.
With high-risk activities, is zip lining considered a high risk?
Probably not. Yeah, so as long as you're strapped in tight, follow the directions of the operator of the thing, I think you'll probably be okay. Sunscreen, no, because you could be up above the canopy, But zip lining, probably okay.
All right. Yes, Norm.
Dr. Goldberg, first off, thank you very much for your conversation with us. It's very helpful. My question concerns NSAIDs. Is there the current opinion through cardiology on using NSAIDs for arthritis. and so
Yeah.
forth.
So the question was, can you use NSAIDs? NSAID stands for non-steroidal anti-inflammatory drug, but to put it into English, it's Motrin, Advil, naproxen. These are the painkillers that people use, but not Tylenol. Tylenol is not, or acetaminophen is not an NSAID. The problem with NSAIDs, and the reason we don't recommend them, is because NSAIDs actually have some toxicity on the kidney, and they also raise blood pressure and trick the body into holding on to salt and water. And so NSAIDs are not routinely used in transplant because tacrolimus and NSAIDs actually work in the same part of the kidney, and they potentiate the toxicity of each other. So people can get pretty significant renal dysfunction when we give them high doses of NSAIDs. And so in general, we ask you guys to avoid them and to stick with things like Tylenol, etc. There are some exceptions. So sometimes if someone has something acute, you can take NSAIDs for a day or two. And we worry a little bit about that, but we don't think but chronically using, like for arthritis, chronically over time, it significantly increases the risk of kidney dysfunction and hypertension, and that's why we don't recommend it. It's true actually across the board now, so anyone who has heart failure, we also say you're not supposed to have NSAIDs because it can cause salt and water retention, and actually, if you look at the Medicare database of older women admitted to the hospital for heart failure decompensation, the #1 preventable cause is that someone prescribed them NSAIDs for some ache or pain, and then they come in with decompensated heart failure. So Medicare has actually now put out a notice to physicians that NSAIDs should not be given and blah, blah, blah. And so we've been sensitized to that because it's been noticed to be an issue out there in the community.
Bob, nice and loud.
Under what circumstances does someone might need another biopsy down the road, or AlloMap, and maybe you can
Yeah.
comment on both?
Yeah, so that's a great question. So as you guys know, or most of you know, that we stopped doing routine surveillance biopsies at year 2. We used to do biopsies forever, every 6 months, like literally forever, like people would be 12 years out, we've been doing biopsies. Then we stopped at year 5 because we realized that we didn't change our outcome, like we did all these biopsies, we didn't find anything. So then we stopped at year 5, and then we started looking at our data for about a year and a half. We were stopping at year 3, and now our program stops at year 2, and that's actually what a lot of programs are doing around the world. The European programs are stopping almost routinely at year 1 or 2. So the question is, when will we do a biopsy beyond that? And there are 2 scenarios when we'll biopsy somebody beyond year 2. One is that we're making a significant change in the immunosuppression that we know has kept you safe for a long time. Say you're having a side effect, or there's PTLD or something, and we know we need to lower the immunosuppression to treat the lymphoma, but we worry, are we going to precipitate a rejection? So we would do a biopsy as surveillance to that change in immunosuppression, so that's one reason. And the second is if you come in not feeling well, or we see a change in an echo, or one of the surveillance, stress tests or whatever, one of the surveillance tests that we do as part of your annual. That would trigger a biopsy to make sure we're not missing something. As you know, there's 2 types of rejection, cellular, which we see more in the early phase, and then antibody-mediated that we may sometimes see later. The other part of your question was around AlloMap, and the problem with AlloMap over time is that as you go out further and further from transplant, the AlloMap scores tend to change and drift upward a little bit, and they eventually drift upward into, is this person rejecting or not, range. And so the AlloMap sensitivity for rejection beyond your, say, 4 or 5 becomes less and less as people are further out from transplant. That being said, there are going to be new non-invasive biopsy ways. So cell-free DNA, which is made by the same company as that makes the AlloMap. I actually went out and met with their engineering and technical staff about 2 years ago to see what they're doing. Penn is actually doing a large cell-free DNA trial right now in kidney. So we always mooch off of them first, right? We let them, we're like, yeah, dude, that's a good idea. Go ahead. Just let us know that worked out. Then when we feel like, all right, this looks like it might work, then we'll do it on the heart patients, right? So we always make the kidneys. They do 400 kidneys a year, so they can do clinical trials much quicker than we can. And so there may be a different than AlloMap, but actually maybe cell-free DNA may be something that we could use indefinitely. Like it shouldn't change over time. One of the things we don't understand with cell-free DNA right now is how would we detect, say, antibody-mediated rejection with cell-free DNA, but cellular definitely can be detected. And so there's some early studies there. So we probably in the next 3 or 4 years will have a non-invasive way of detecting rejection. And whether we'll apply that to people that are 10, 15, 20, 25 years out or not, we still have to debate about. But it may change the number of biopsies and how we do it. Most of the non-invasive tests are not good at, even Alamap is not great in the first 6 months after transplant. So chances are we'll still have to do real biopsies then. But after that, we may be able to switch to a non-invasive test. So more to come. This is a hot area. The good news is the kidney folks want it, the liver folks want it, the lung folks. So that, if it's just heart that wants it, we're a small group. If you think about like cancer, and then like how many, there's a couple, 2,000 transplants a year in the country, and millions of cancer patients. So we don't always get the traction that we need politically to kind of get funding and stuff. But here's an opportunity where across all the transplants, everyone is interested in non-invasive ways to detect immune tolerance and also rejection. So I think we'll probably have something.
Interesting, just the other day I was talking to Robert out in CareDx, who's the director of research out there, and AlloSure, which is the kidney version of Alamap, is really taking off around the country. And I really was interested in I'd been out there a couple of years ago talking to that company, and they were working toward being able to detect cancers using their technology. So I was really trying to get an update for our cancer website on what they're doing in that area. They're not developing a test for cancer as much as they're partnering with all the different cancer research going on and trying to figure out a way they can use their technology that they use from Alamap and AlloSure to help identify cancers that are being researched in other areas, what are the identifying factors. And so this is really a very, very positive support for exactly what you're saying in terms of where are we going in less invasive ways to prevent or catch those things early. So important. Another question. Yes, sir.
Yeah, at my annual it recommended colonoscopy, and I went ahead and set it up, and the day before I get a call that they submitted it to insurance, and Medicare says they don't consider it high risk,
Yeah.
and I have to pay out of my own pocket. So
Yeah,
I
so
canceled
let-
at that
so-
point because I felt okay.
Yeah. So let us know when stuff like that happens, because being a transplant recipient itself is considered high risk. So we can push back on
Because
that.
they kept submitting it, and they kept coming back.
Yeah. Let us fight that battle for you a little bit.
One other question, what kind of medications do you recommend for osteoporosis?
So it depends on the degree of osteoporosis. So sometimes we recommend calcium and vitamin D supplementation just to replace calcium. Sometimes we may recommend bisphosphonates, which are the drugs that are used to treat osteoporosis in older women. And then occasionally there's some IV drugs that can be used if someone has severe osteoporosis or injectables that we use. We defer, once we get to bisphosphonates, we actually ask the experts to help us because it's a really changing field. Like the stuff that I learned a number of years ago is like, oh, they never do that anymore, So we do defer to someone who spends their time in bone metabolism to kind of help us with that.
Question. Yes. ma'am.
Is there a risk factor to a family member getting a live vaccine to the transplant patient?
Yeah, so there's a small risk that for about 48 hours after a live vaccine that it does put the transplant recipient at risk. So staying away, washing hands and stuff like that is probably a good idea. And that's true for the grandkids, right? The little grandkid gets a live vaccine, which they typically do when they're little, to stay away from them for about 48 hours afterwards. And actually for our staff, if one of our staff gets a live vaccine, they have to stay home for 2 days as the hospital policy for the same reason. Because there's a small theoretical risk of transmission, so we keep everybody away. It's a small risk, but it's not zero.
And it's a good reason to say, no, I'm sorry, I can't change that diaper,
Yeah.
or I can't empty the cat litter. My doctor told me.
Yeah, I'll give you a note for that.
Question. Somebody over here. Yes.
I got a simple one. Is there any point in time where you can foresee not having to take anti-rejection drugs, where the body would say, hey, it's not far and I've had it X number of years, you got cell exchange going on?
Yeah,
I'm
I
hoping
wish.
you've got.
So for the people in this room, the answer is no. That we think that you will not develop tolerance to your organ to the point where we can stop the immunosuppression completely and have no risk of rejection, even 20 years out. What I can say is that there's a whole bunch of work going on, and a guy named Jordan Madsen, who's a cardiothoracic surgeon at Mass General, who I trained with a long time ago, has been spending his career in immunology. He's a surgeon, but he actually has a lab that does immunology. And they now have transplanted a couple of kidneys and develop what's called mosaicism. So there's kind of the immune system has some components of the donor and some components of the recipient, and have developed tolerance. And they have, I think, 4 patients now that got kidney transplants and are on no immunosuppression, and the kidneys have been fine, and they're at a couple of years now. And this has created a big buzz. It has not been duplicated in heart and lung. They haven't been able to induce that yet because the heart and lung are much more immunogenic. But he's on to something, if you know what I'm saying, so we'll see. The problem is we have to do the therapies of tolerance before transplant or at the time of transplant in order to induce it going forward. But once you've been transplanted, we don't know how to go back. So for you guys, you'll have to stay on the immunosuppression indefinitely, but there may come a time in the future where we'll be able to do something different. And we'll see. We're a little anxious in the heart transplant world because the one clinical trial that was attempted, which was a bone marrow exchange with the donor at the time of transplant, interestingly, the results of that trial were pretty disappointing, and they were disappointing in a really bad way in that they actually caused more rejection because they sensitized the recipient, and so we stopped doing that. We thought that if we gave a little bone marrow, we'd get this mosaicism, but all we did was sensitize. And so we made it worse. Even though it works in lab animals beautifully, it doesn't work in humans very well. So that's gone out the window. What Jordan is doing is actually a more intensive way of transferring bone marrow. He's actually like doing a bone marrow transplant. They literally ablate the person, do the transplant, and then infuse the donor bone marrow, and then create this kind of mosaicism. But a lot of our heart patients probably wouldn't tolerate like getting full dose chemo at the time of their transplant because they're already pretty sick and have other things going on. So there may be other techniques that'll come along. That's not 2 years away, that might be a decade or 2 away, but he's working on it. And the fact that they were able to do it with kidney is, I think, is giving us hope that there's something there, but we have to kind of see what's going to happen with heart and other solid organs.
The kidney side of that is fairly new. What you probably have heard over the years is the success with livers doing that.
Yeah.
Again, very few, but it does work. Liver is a very different organ. So when you hear stories, you're probably hearing about long ago liver tolerance.
Yeah.
Now, as you said, in the research area, kidneys, not going off your meds. Stay with them. Somebody had a question down here. John?
Yeah. Dr. Goldberg, first of all, thank you for many years. I have a question personal. Last week I was told that I may need surgical intervention, not on a coronary artery, but on a peripheral artery. What kind of coordination should there be between the surgical team and the transplant team?
Yeah. So we usually will do what's called a pre-op clearance or a pre-op risk assessment for any surgery, including vascular procedures. And then the coordination for us is we want to know 2 things. One, is there going to be a big strain on your heart from the procedure? Most peripheral vascular procedures, there isn't a big strain, but big open procedures like in this aorta and whatnot are a bigger risk. So we want to know the risk to your heart. And then we spend a lot of time coaching the surgical teams around, don't let you miss any immunosuppression. So if you're really nauseous and you can't take your pills, how to give them IV and sublingual, to make sure you don't miss any doses. Do you need stress dose steroids, and kind of reminding them of that, because sometimes the surgeons and the anesthesiologists are not thinking about those kinds of things. So that's the type of coordination we do. And if the procedure is not being done in one of our hospitals that we can kind of see what's going on in the chart, we provide them a 24/7 number to call so that they can get one of the nursing staff or one of us on the phone if they have any question about your immunosuppression drugs, about side effects, about what to do. We had a scenario recently where someone had a surgery and then there was concern a few days later that it looked a little red, was it infected? And the response of the surgeon was, oh, we'll hold the tack in the cell set for a week and let's see if that gets better. Because if you give someone antibiotics, it counts as a surgical wound infection against your stats. So I was like, oh, no. So the patient called and I was like, no, don't do that. So we got a hold of them and said, let's try some antibiotics and keep the tack and cell set going. So stuff like that we want to make sure, because not every clinical person, you guys have probably experienced this, is as familiar or comfortable with transplant. It's scary because they don't see it a lot. They don't know what they're doing. Some are awesome and they partner with us and it's no problem at all. And others are really anxious and they need a little bit more support. So we usually connect with the surgical teams to make sure that they know what they're doing. And that if they have a question, they can get a hold of us quick and we don't let anything go out of control.
But don't forget, there's one person that's really in charge of your care. That's you. And so when you're in those situations, if they're not doing what you have heard they should be done, you pick up the phone and let them know what's going on. Get them in there in case some other hospital says, oh, I don't need their help. We're good here. Nah, don't let them do that to you, okay? You are, and your caregiver, get right there and listen to that caregiver. The caregiver sees things that we, especially us men, say, oh, no, it's no big deal. No, the caregiver sees things we don't see. So pay attention, give them the respect they're due, and follow through on what they're suggesting. And then you can say, see, I told you it was nothing. Okay, good. Yes?
So you mentioned earlier that if you have like diabetes beforehand, you have diabetes after kind of deal. Because it's a transplanted heart in this situation, are you more likely, like genealogy, to develop it because of who had it beforehand or not?
No. So that's a great question. So are you at risk of inheriting or developing the diseases, say, from the donor, right? And the answer is absolutely no. So there's no data for that. The one exception is obviously if there's something structurally abnormal of the transplanted heart, then obviously we have to follow that. That doesn't happen too often because we screen for all of that at the time of transplant. But no, if the donor had diabetes or had some other issues, those are not transmitted things to the recipient.
Okay, a couple more questions. Let me go up to the top in case so I'm not ignoring anybody. All right, back down front, yes.
I have a question, Dr. Goldberg. The recommended A1C level, because you read things in literature and it will say it should be below 6, but yet I think my recent one was 6.2 and I was considered, that's great.
So this is also a moving target. So the below 6 refers to either the diagnosis of diabetes initially and defining like who that is in the US, which has been super controversial. And then secondly, what the target goal should be. So in the past, over the past 5 or 6 years, there was this thought that we had to be super aggressive and push the hemoglobin A1C really low. And a number of clinical trials have come out in the last year that suggest that there isn't much benefit to going that low, and there's a lot of side effects and problems, and people have a terrible quality of life. So we've now raised the level back up to 7 as the target, so under 7. So we're shooting between 6 and 7 typically. If it's under 6, that's awesome, and you get a high five, and we're happy. But we don't go nuts if it's in the low 6s or mid 6s now. But the fact that it was 6.2, you get a big hug from me because that's good, and it's not easy to achieve for a transplant patient because the other meds just make managing the sugar more difficult, and you got a lot of balls to juggle with all the other meds too. So the fact that you got it under control is actually. That's a thumbs up.
1 or 2 more. Yes, sir. Tom.
Doctor, you were talking a little bit when you went through the immunology of different things. I met a patient here yesterday. I don't want to say his name. He's been transplanted for 10 years, and he's starting to reject. What are some of the telltale signs that all of us should look for to prevent that?
Yeah, so that's a great question. So this gets back to the concept of report to us things that are different, right? So if you have shortness of breath, that's new. If you normally can walk on your treadmill for 30 minutes and now at 10 minutes, you have to stop. If you notice other symptoms, we want to hear about that. Because those sometimes are early warning. We're only seeing people out every 6 months, right? And so 6 months is a long time, right, in between. So you are the ones, you're your doc, right? You're the ones that are the early warning signs for us. So if you call and say, I'm not feeling well, I promise we will respond, right? Typically we'll say, come in, let's get an echo, let's see what's going on. Many times it's not cardiac, but that doesn't matter. Like we would start there to kind of figure it out. So it's really up to you guys to give us that feedback. And that may be a clinical change that would generate a biopsy, say at year 8 or 9 or 10, because something is changing and we want to make sure we're not missing something in that regard.
One more? Oh, yeah. Yes, sir.
Yeah, precautions a transplant person should take if they are going on a cruise or out of the country particularly.
Yeah, that's a great question. So there's a couple of, it depends where you're going. So there's like out of the country and then there's out of the country. Right? So if you're like going to be like in the middle of Africa and we have to worry about yellow fever and typhoid and stuff like that, that's a different scenario than I'm going to Rome, because it's just a little different scenario. So the typical things that we recommend for people to do are the common sense things. So number 1, tell us how you're going. so that sometimes we can provide kind of a medical summary. If you have access to My Pen Medicine, anywhere there's internet, you can get copies of your records wherever you go. Typically, if you're going to carry a lot of pills and stuff through security and customs, you're going to want a note from us saying, hey, I'm a transplant recipient, here's a med list, and signed by us and a phone number so that, you know, the authorities don't think you're smuggling in whatever, I don't know. Who would be smuggling tacrolimus, but nonetheless, you never know what can happen. But nonetheless, so those are one thing. In terms of the medical issues, if you're on a cruise or whatever else, cruises are notorious for transmission of viral infections like norovirus and GI illnesses and whatnot. So this is where frequent hand washing, common sense, that kind of stuff is going to be key. And then if you're traveling somewhere where there's absolutely no access to like transplant level care, I would say, then having some type of medical evacuation plan, like some of your credit cards will have that, where they can get you out and get you someplace where you can be in an emergency, or you can purchase one of the travel insurance for that. If you're going somewhere that has that, like anywhere in Western Europe, or, you know, you'll be fine. But if you're traveling someplace pretty exotic, then that's that. If it's super exotic, let us know, because we'll actually go back to Transplant ID and ask them, is there anything specific we should, number one, tell you to avoid in that country? And number two, are there any immunizations or should you be taking anti-malarials as prophylaxis, et cetera, et cetera. And so let us know that if you're going someplace super exotic. And there may be a few places where the recommendation will be you probably shouldn't travel there as a transplant recipient because the food supply and the water supply is just not great for an immunosuppressed person, and the risk is just too high. That happens sometimes. We don't get a lot of requests for super exotic places. People want to go to the regular fun places, you know, now that they're free. And so, but if you have something like that, let us know, and we'll ask. Just let us know before you put down a big deposit, so that in case it doesn't work out, we can abort that plan and recommend a nice place in Rome for you to hang out.
Thank you. One last question. Go ahead, real loud.
Preparing food and making dinner, is there any precautions we should have?
Yeah, so I have one slide about that to avoid raw or undercooked meats, and eggs are really important. And right now in the US, we're having a big problem with salmonella in eggs, so avoiding raw eggs. That's not true for you guys. I mean, it's true for you guys, it's true for everybody. And now we have a big issue around E. coli in the lettuce and whatnot, so making sure that we're washing fruits and vegetables, and no undercooked meats, raw seafood, or raw eggs.
But how about preparing, like cutting raw chicken?
So cutting raw chicken should be okay as long as you're washing your hands afterwards. The only thing I worry about is if you cut yourself while you're cutting the chicken, just to make sure that you really clean that wound carefully. But handling raw food should be okay.
You don't need gloves or anything?
No, typically we don't recommend it. You can if you want, but that's usually you're okay. It's usually ingesting or inhaling that people get into trouble.
Thank you.
Lee, thank you very much.
Thank you.
Couple things. One, a little gift from us, Mark Anderson's DVD for you to enjoy. But also, I want to say the thing we look forward to in your presentations is they're so clear and the actions are so easy to understand, aren't they? Yes. I mean, things to do. Now, Dr. Margolis did a great presentation in the fall. A lot of people said, a little over my head. But you felt good listening to it, didn't you? Yes. And you can go back and watch it on YouTube, all right? And he's doing the research part of that. Yeah. But really, when you come down to this, where you can really understand it. And I'm going to add, from a personal story standpoint, some support for things you said. One, the message I give people is find it early, and it becomes part of your story as a part of, instead of part of your epitaph. Okay? One of the values of our transplant team is they're not just the transplant team. They're part of a network, and when they refer you to dermatology or diabetes or whatever, these are people that they've worked with, and they know, they understand the transplant dimensions they don't see in other patients. And so that network, I think, is where I see a difference when I look at programs around the country. It's not just the ones you see directly, it's the ones that support them that they go to for advice in specializations. Back in 2000, I was diagnosed with prostate cancer. I'm going to talk about cancer just for a minute because that was a main emphasis there. And when I went to the urologist, they said, oh, it's not a problem, it's slow growing this. No, I'm a transplant patient. Things are different. I want, what's the gold standard? It's a biopsy. It was a painful biopsy, but they did it a couple times and finally found the prostate cancer, and we treated it, okay? And so it's been 18 years cancer-free from prostate. Then later on, in 2006, came down with diabetes. Great clinic here, been totally under control, 6.1 just yesterday, all right? And so, again, that team, skin cancer, has been treating them for years now. Dr. Miller and his team, I can't say enough about it, they are world class. And his presentation is up on our transplant presentation library for you also. But this team, all together, when you catch things early, they get taken care of. In 2012, again through that emphasis on looking for things early, they found kidney cancer. Oh my God, all right, what are you going to do with it? They took 2/3 of one of my kidneys. I'm fine. And that's been 6 years ago. So my point, especially to the people that are just out a month, 2 months even, a couple of years. These things are things that you can treat, live through. You're going to get older. Guess what? You're going to get them, like he said. Make sure you're working with the team, take care of them early, and they become part of the story like I'm sharing with you now. By way of hopefully inspiration to you to do what he told us to do and be back here in the fall and the years to come sharing how far you are out from your transplant. Lee, I can't tell you enough about how clear that all was. And with a little bit of luck, I may get this up on YouTube tonight. We're going to be on that graduation next 3 days, but I'm all set to do that. Maybe even get done before midnight, okay? Lee, thank you again. And so you already thanked our social worker team, but I wanted to make sure that from our patients, we also say that. Social worker team, would you stand up for 1 minute? Some of the new people, they won't know you. So Deb just left out this door.
I think they're out setting up.
They're all setting up, okay. We're getting our lunch together. And we also have other staff in here. Who else is from the hospital staff? Just stand up so you can be recognized. There we go. And thank you for all you do. And don't forget, add your contact information to the sheet out there. Pick up your parking vouchers if you don't already have them. Enjoy the luncheon. And by the way, don't sit with somebody you know. Find somebody new. Sit across them. The one thing about our environment is it's really easy to start a conversation. So, what did you get? When did you get? How you doing? I mean, it's easy. And so I'll see you at the next transplant event here in the fall. We don't have a subject yet. We don't have a date yet, so stay tuned. Lunch is now served. Thank you for coming out.